conflict of interest or financial disclosures to make. And I just want to make sure that everybody can still see my screen in show. Okay, awesome. I do want to share, I am consider myself a New Yorker. I grew up in New York City, in Washington Heights, actually. And though I haven't lived in the city since after college, I still read the New York Times every day. And so I'm very much a New Yorker at heart. And so getting to spend some time with you this afternoon, even virtually, is really special. So I want to discuss the components of the IM Core Clerkship grade and what we found in our study of US medical schools, and then share with you some of the things that we learned from asking internal medicine clerkship directors about their perspectives of the components of the grade and the process that they go through to generate that final evaluation for students. I want to acknowledge my collaborators, folks from multiple institutions that worked on this project. And ideally, grading in the clerkship is based on multiple assessments, based on direct observation of learners on multiple occasions. They include multiple domains that we're familiar with assessing that reflect the expectations we have for students and what we'd like them to achieve as they develop their competencies to become a physician that can practice under supervision. We'd like our assessments to be reliable and valid and as they contribute to the grade and free of bias. Our grading and assessments should ideally inform the learners of how they're doing and how they're progressing to meeting the competencies of becoming a physician. And then the process should give us some information on the programmatic level on how we're doing in terms of our educational program and helping develop learners and help them accomplish the goals of our program. However, as I don't have to tell this audience, all of this is happening in a very complex environment, in an environment that's not designed for assessment necessarily of the learners and all the domains that we want to observe. And increasingly, I've practiced as a hospital, it's like a good portion of my career, and I've been focused more on education since I've been at UCF. And I think even in the last 5 to 7 years, the pace of things, never mind COVID, has really changed. But I feel for faculty when we're asking them to do a lot of tasks of observing learners and filling out lengthy forms on multiple learners at the same time in the contemporary clinical environment, where really the principal priority is the care of the patient. They're increasing regulatory and compliance requirements, never mind the EHR. There's decreased continuity in terms of relationship with attendings, with residents. And those are things that are dictated and influenced by institutional culture, resources, and different priorities, including our educational program. In our institution, we've wanted students to have the ability to do electives earlier on, since some of the subspecialties like ENT want students to have done electives before they apply. So we've ended up shortening some clerkships, and the time that they have to sort of dwell and interact with supervising residents or attending has really diminished. We also have students who go to multiple sites, even during a 4 or 6 week clerkship. We also have accreditation and licensing requirements that we have to uphold and adhere to. And we know that in this context, as human beings, we're susceptible to bias, and that the current grading approach in the clerkship really is a source of stress for students that has impact on their well-being. So in the midst of all of this context, we realize that there are limitations and imprecision. Our measurements are imprecise. And this is not a new finding. We have our articles in the literature for several decades. And really 2 decades ago in the early 2000s, the AAMC struggled with this and tried to set standards for professional attributes for consistent procedures for performance-based assessments and modifications to the MSPE. Despite that, the concern with sort of variability and imprecision continued. And one of the first sort of studies that looked systematically at this across US medical schools was this study by Alexander. And they wanted to look at inter and inter-school variability and the meaning of the grade. So it really was the first review. They conducted it in 2009 to 2010, and at that time included 119 of 123 medical schools. And not surprising, they found a lot of variability in their grading terminology. They also found variability in the number of tiers, anywhere from a 2-tier system, so pass-fail, to one system with 11 tiers, which I can only imagine. And they identified that issues like grade inflation, which we certainly struggled with in the internal medicine clerkship for some time, really was influenced by the number of tiers in the grading system. And so for those systems that had 4 or more tiers, there was an increased proportion of students receiving the top clerkship grades versus a system with 3 grading options. And this is a table from their paper, and they looked at it across the different clerkships. But overall, you can see that the mean for clerkships with the top tier, if they had 4 tiers, 33% of the students received the top grade versus 23% in 3-tiered system. So even how the grading scale and the grading system that we use in of itself influences some of the outcomes that we see in terms of variability and challenges with reliability in our clerkships. They also looked at variation within an institution. And there have been subsequent studies, and this really has not changed as much as we would like to imagine that it has. And the variability is impressive. And I included this because it still impresses me, and I think that it's probably more common than we think. And in one school, the variation between the percent of students that top score in school 1, it was 81% in family medicine versus 18% in surgery. So 63% sort of intra-school variation, and that really was not a rare finding. And certainly in our institution, one of the things that we have struggled with is deciding, how much similarity in the way things are approached and standardization do we need across clerkships, and it's a continuing dialogue. And I'm not sure that we have found the answer, but certainly Alexander and colleagues demonstrated that. Similar findings by Fazio and her colleagues, which were published in 2016, also from a CDIM survey, found that grade inflation was a concern in the internal medicine clerkship. And it seemed to emerge from faculty not wanting to adversely impact students' potential applications or competitiveness for residency. So while there was a great concern for the significance and impact of grade inflation, there was that tug of not wanting to adversely impact students. And one of the things that emerged both out of Alexander, Fazio, and other studies during the past decade or so is really a call repeatedly for some standardization of the terminology of the language that we use. And that continues to be a challenge today. And I'll share with you shortly what we found. There's also, I think, a significant awareness over the last several years from work from folks like Karen Hauer, Kathleen Lucy, and other folks on this illusion that we have of objectivity and the sort of power that we attribute to a number. And I think awareness, we probably all sort of intuitively understand the challenge of taking multiple complex domains, competency constructs, and reducing it to a numeric score. But that has been such the mode and such a default that it's very hard to change that, despite, I think, this awareness that we realize of the disservice that may do to learners and our eventual goal of graduating competent physicians, and about some of the inherent bias that introduces into the process that may be counterproductive to some of the things that we want to achieve. Intrinsic motivation, wellness, dealing with some of the stress that our students encounter that may adversely impact them in their performance. I know that Dr. Howard has spoken to you, and so many of you have heard from her and some of the things that places like UCSF are doing in terms of sort of being innovative and trying to change towards sort of a programmatic approach to assessment and moving away from the traditional grades. That has been challenging for other institutions, and I don't know that that'll be generalizable, but I'll discuss that a little bit further as we move forward. Obviously, this is part of a broader conversation. Many of you are familiar with the work of the Coalition for Physician Accountability and how they're trying to improve that transition from UME and GME. But the other thing that's very telling, and I normally do not go on Reddit or any of those social, those related sites or doctor network, but I was advised that I should check it out. And so there are over 4,360,000 entries related to grading in the clerkship and Reddit, if you wondered. So this is very much in our students' mind. Certainly trust around assessment and grading and evaluation is an issue. On trust from residency program directors, from educators, and also from our learners. So this is sort of happening in a broader context, but I did want to mention this because one of the things that we've seen is increasing number of challenges from students in their clerkship grade. And I had a colleague in my office, one of my faculty, who said that this month she has 4 challenges, where in past years she had 4 the whole year. So I think that being aware of that broader context is really key. And just the Coalition for Physician Accountability really is asking us to define a common framework. And I think that relates to use common language. And then really trying to eliminate this systematic bias that some of these assessment methods and evaluations and grading approaches introduce. And one of the things that we have yet to do at our institution is this sort of initial and annual exploratory review of grading, patterns of grading. Despite having a pretty robust program evaluation subcommittee, we certainly have work to do in this area. So what about the learners? For learners, despite what we know are the limitations, variability, and challenges with grading, they're still in place in many of our institutions. Few have gone to pass-fail in the clerkship, and they really are high stakes for our learners. They influence class ranking, awards for institutions that have not eliminated AOA. I know that ICAMP has, but many institutions continue to have AOA. Grades will factor into that. They may factor into scholarships, away electives, and residency selection. And while the majority of schools have gone to pass-fail for the pre-clerkship period, and this is from the most recent LCME questionnaire, and it's available on the AAMC curriculum report website. I included the link and just has the data, and I think it's always really helpful. And our study looked at data from 2018, but even in the past couple of years, it seems like the percent of schools going to pass-fail has certainly increased. The schools using, so that's a 2-tier system. Schools using a 4-tier system for clerkships are very small, so 6 this past year. However, that's not the case for grading in the clerkship. So in the clerkship, we see that 4-tier system, despite some of the challenges, yes, that's 4 tiers, 1, 2, 3, 4, continues to be the grading approach for most of the clerkships. So again, the challenges presented by generating grades in the clerkship are things that we really need to sort of attend to. And then from students' perspective, this is from the most recent NRMP survey of residency program directors. in terms of contributing to, this is deciding whom to interview. Grades and clerkships are still ranked fairly important, 3.9 out of 5. For the internal medicine clerkship, it's just slightly lower, but 75% of the program directors who responded to this survey utilized the score as a screening. This survey, although there were over 1,000 responders, that only represented a 23% response rate. So it's something to keep in mind, but it can gives us a little bit of a window into what program directors are using to try to make decisions about screening and interviewing, particularly as the volume of applicants have increased in the last several years. So one of the things that I wanted to understand, and as well as my colleagues, is, we know we have some idea about what we'd like to do in terms of assessment evaluation, moving towards programmatic assessment, multiple sources of feedback assessment for learning. Yet, certainly at our institution and others, we still struggle with what we're actually able to do, and the way we're certainly evaluating and assessing students in the clerkship and generating grades. And so that there's this gap, and the contributors to the gap and the size of it may vary at different institutions, but I think it's a common challenge that we have. And one of the thoughts, certainly that behind our study, was let's understand what the current practices are. In particular, what are all the elements that are contributing to the grade in the internal medicine clerkship? And by defining those and asking clerkship directors their perspective, can it give us some insight on why we're really not moving forward with really some of the things that are best practices, or exploring and identifying best practices? Because there's certainly need for evidence on what's the best way to do things, but there are certain things that we know. So what accounts for this gap, and how might looking in depth into the components of the grade help us? And that's really what we set out to do, is, what are the components that contribute to the grade? And we took a deeper dive on two of the major components, which were the clinical performance assessment and the NBME shelf exam. And we also spent a lot of time talking about the NBME shelf exam at our institution. And it was just a year ago that we stopped using it as a criteria for honors. It's still an issue, I know, for many institutions. And then really trying to decipher some of the clerkship directors' perceptions on the NBME and use of shelf exams or other standardized exams, and some of the influence that may have on students' learning. So our survey and our study was part of the Clerkship Director in Internal Medicine, a charter organization of the Alliance for Academic Internal Medicine. And they've been conducting annual surveys since 1999 to address sort of relevance and issues to medical educators and in internal medicine. And our survey was part of the 2018, which was disseminated to 136 medical schools. There were 2 redundant clerkship directors listed in the initial list. Once those were eliminated, we identified 134 distinct individuals identified as the clerkship director at those institutions. Our section of the survey had 22 questions, some multiple choice. The majority were 5-point Likert scale with open text responses. And the response rate for the survey was 82%. And we started by looking at overall grading practices. It's been 10 years since the Alexander's, well, it had been 8 years since the Alexander study. So have we made progress? And what we found is that still, half of the internal medicine clerkships reported using a 4-tier scale. And it'd been a few years since Fazio's study as well that showed the correlation with some grade inflation. So that seemed to be something that was persisting. Interestingly, when in the text box, there were 13 schools that indicated other. And I'm including this. I don't think we listed this in the study, but we were just tickled by all the different terms that people utilize, especially trying to decipher the distinction between honors and pass with commendation and honors and near honors. So it was just really interesting to sort of see and wondering what people are trying to accomplish with these distinctions and with the this taxonomy, right? The wording choice. What's driving this wording choice? In terms of summative assessments used to determine the grade, the majority of the assessments, most of the programs, schools utilize the NBME and the clinical performance assessment. And in terms of the weight, the NBME was about 25%, and a greater weight was associated with the clinical performance assessment, which is sort of gratifying to see. And despite really an increasing number and types of assessment contributing to the grade, for example, there has been a significant increase in use of OSCEs over the last 2 decades, oral case presentations, online cases, and the like. Really, the NBME and the clinical performance assessment were the major contributors to that were utilized for the grade. In the orange bar, you see the must pass. And what was interesting was that for nearly over 90% of schools reporting, the NBME was a must pass. The clinical performance assessment was not identified as a must pass. There may be different reasons for that. The clinical performance assessment might be a source of really important narrative feedback that's not quantifiable and perhaps is not indicated as a must pass, but it certainly was interesting and I think a source of questions and perhaps further exploration on what accounted for this. Similarly with professionalism, professionalism is a very area that we have been emphasizing increasingly and certainly is important, both during medical school and further on during training. And that similarly was not, I just barely identified by a little bit less than 50% as a must pass. And similarly, it may be treated more as a qualitative item, but it was sort of interesting to sort of see that, and it generated a lot of discussion, certainly in our study group. The other thing that we learned is that still the clerkship director alone determined the clerkship grade in over 55% of the responding schools. So really a great deal of the work in generating grades still is borne by the clerkship director, which I'm going to mention a little bit, come back to a little bit later. But it just represents in terms of particularly with increasing class size, really the bulk of the responsibility and work still is in the purview of the clerkship director. When we try to explore and what is leading and driving some of the utilization of the NBME exam, some of the things we asked are, how important are the following in your choice to the clerkship director? And certainly, not surprisingly, benchmarking and national comparison data was sort of one of the leading causes or leading factors. I think most of us for LCME accreditation in our DCI, they asked for national comparison data, so that's not surprising. Also, this perception of, these exams is sort of highly, quote unquote, reliable and quote unquote valid, despite the fact that many of these are retired NBME questions. It's standard of practice nationally, so some standard at the national level. They're perceived as time efficient as opposed to generating school-based exams. And those were some of the kind of the major things. There certainly was this idea that it's important to assess medical knowledge and that perhaps we're also helping students prepare for step 2 CK by having them do the shelf exam. For the institution, the clerkship directors perceived that that was a major reason for using the shelf exam, that was important to institutions. But yet it didn't seem to be a very effective measure of the clerkships and how well it does, or certainly the effectiveness of the clerkship director. Interestingly, when we asked how well they thought the assessment aligns with the clerkship content, just about 60% some said they were very or somewhat confident. And we know that there's been certainly clerkship directors of internal medicine have expressed some concern to the NBME that content in the exam doesn't necessarily align. For example, there's a bit of neurology, which may or may not be covered during the clerkship. So again, it's not ideal match necessarily for content that's covered in the clerkship. One of the most significant findings, I think, was this idea of what are the consequences potentially of a shelf exam. And we asked them how concerned they were that a student's focus on a shelf exam, either as a must pass or as a criteria for a top score, influences the students' studying and the use of their time and detracts from patient care. And some are very concerned, just almost 88%. So really a significant number of responders expressed this concern. Yet, you know, when we asked them, have you changed? 56% said no. And how likely are you to remove it from the final grade determination? You know, 81% were either very or somewhat unlikely to remove the shelf exam from determining a grade. Why was this? So certainly the barriers to removing the subject exam as a summative assessment, right? Not necessarily formative, but summative, was really sort of the mandated by institutions for all clerkships. And that again may get to some of the accreditation requirements to have comparability of across institutions and provide that data in your DCI. This perception of the shelf exam as quote unquote objective and objective quote unquote assessments being superior to observations or subjective assessments definitely influence things. And lack of other non-MCQ formats with perceived high reliability. So those are some of the factors that really seem to be barriers to making changes in how we use these standardized assessments. Briefly, just in terms of the clinical performance evaluation, we found that there was a lot of variability here as well. Equal number of attendings in terms of both attendings and residents filled out. So it was about a third of responders said that attendings filled out the clinical performance evaluation. A third were completed by residents. And they're really, most of the evaluations were done independently or used independently and then combined, 36%, 50% were all combined into one and not used independently. And most of the clerkship directors gave equal weight to all the evaluations, regardless of the type of rotation. So whether they were doing a sub-rotation within the internal medicine clerkship or whether it was completed by residents or attendings. So, you know, our findings were that assessments and grading practices in internal medicine clerkship continue to vary widely, which really, I think, undermines the trust both that learners have in our evaluations as well as residency program directors. We have this continued reliance on standardized exams, such as the NBME shelf exam, and it remains a significant must-pass component for schools. There's really no standard way of compiling the CPAs. So for example, weighing the CPAs for more experienced evaluators, people who've been teaching and evaluating students for a longer period of time or who have longer contact time with learners. And most notably, especially because of repeated recommendations over the years to try to come to some consensus on a language or taxonomy, we really see varied use of terminology for scoring and grading learners. And for me, the most concerning is the choices we make around assessment and grading and its impact on learners. I also, this is pre step one going to pass fail. So what's going to happen now with step one pass fail? How is that going to impact? What are the potential consequences in how students seek to distinguish themselves in the clerkship? And I think that's going to be a very important thing for us to pay attention to. And for me and my colleagues, the issue is, are we assessing and measuring what we say matters? Is there alignment? And are we communicating that to the learners? And I think that that's really sort of an issue that we struggle with. Possible next steps, there's progress being made, certainly in the effort to enhance the UME to GME transition. How we help institutions overcome some of the barriers, I think is going to be a challenge. But at the very least, can we start with some common language and taxonomy? I think that that might be a really reasonable place. And then as a chair, I'm particularly interested in things such as recently, I think this is 2021, there was a updated version of expectations of and for clerkship directors from the Alliance for Clinical Education. And it advises or recommends that a clerkship director have a 0.5 FTE for their role as clerkship director. But we know from GLOD and others from 2020 that only about a third of clerkship directors have a 0.5 FTE. So, if they're doing the bulk of, the generating of the grade, are we dealing with some of the barriers to moving our evaluation and our enhancement of grading for the students forward? So I hope that I have left plenty of time to hear questions and ideas from you.